Welcome to another lecture by MedicoMedics, Renin-Angiotensin-Aldosterone System. Now, the Renin-Angiotensin-Aldosterone System, or RAAS, is a critical hormonal cascade that regulates blood pressure, fluid volume, and electrolyte balance. It plays a central role in maintaining cardiovascular and renal homeostasis, and it is a major target in the treatment of hypertension, heart failure, and kidney disease. Now, its main physiological functions include maintaining blood volume and blood pressure, and it does this through vasoconstriction and sodium-water retention. So, by constricting our vessels, we elevate our total peripheral resistance. The same way, if we retain fluids, we increase our blood volume, also impacting our blood pressure. So all in all, the RAAS cascade plays a key role in maintaining blood pressure by influencing both the total peripheral resistance and indirectly cardiac output. Now, let us just briefly revise some anatomy here. So we have our renal arteries. These bring oxygenated, unfiltered blood from the aorta into the kidney for filtration. Naturally, we also then have our renal vein, which carries filtered, deoxygenated blood away from the kidney and to the inferior vena cava. Now, looking closer into the kidney itself, we have the renal cortex here on the outside. Now, the cortex contains the glomeruli, seen here, the proximal convoluted tubule, and the distal convoluted tubule. So we can call this the upper part of the nephron. Then we have the medulla, illustrated here. And the medulla houses the loops of Henle, seen here, and the collecting duct, seen here. And these are both crucial in urine formation, of course. So we can call this the lower part of the nephron. Now, to help illustrate and understand this a bit better to avoid confusion, let us remove some of this and draw it again. So we said that the cortex houses the glomeruli. So let's draw it here. This is a glomeruli. We then had the proximal convoluted tubule still in the cortex. We then had the loops of Henle moving into the medulla. Back up to the distal convoluted tubule, again in the cortex, followed by a drop back into the medulla, the collecting ducts. Now, from the collecting ducts, we now arrive at the renal pelvis, seen here. Now, the renal pelvis collects urine from the collecting ducts and funnels it into the ureter, seen here and here. Now, the ureter is a muscular tube that propels urine from the renal pelvis to the urinary bladder, and it does it using peristalsis. And of course, this is where then urine is stored in the urinary bladder. Finally, we have the urethra. It conducts urine from the bladder to the external environment during urination. So let us take a closer look at the nephron itself and the glomerular components here. So we said that blood enters via the kidney via the renal artery. Now, the renal artery branches into afferent arterioles, which then lead to the glomerulus. So looking closer, we have the afferent arterioles seen here. So we have blood coming here from the aorta, from the renal artery, branches into afferent arterioles, leading then into the glomerulus. And now in the glomerulus, blood is then filtered into Bowman's capsule, initiating the formation of filtrate. And you can see Bowman's capsule illustrated here. Now then, this filtrate then travels through the nephron. So the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and collecting duct. Now, how do we connect this to the RAAS system? Well, at the level of the efferent arteriole. So let us illustrate some cells here at the level of the efferent arterioles. If you want, take a look at this illustration here. Let's draw some of these cells out. Now, at this level of the efferent arterioles, we have juxtaglomerular cells. Now, these form part of the so-called juxtaglomerular apparatus, along with macula densa and mesangial cells. Now, these juxtaglomerular cells are located in the wall of the efferent arteriole, and these are specialized smooth muscle cells. And what they do is they sense decreased stretch of the arterial wall. And this would therefore reflect a low perfusion pressure or low systemic blood pressure. So what happens then when these juxtaglomerular cells detect a reduced perfusion or stretch of these arterial walls? Well, they release renin. And this begins the activation of the Renin-Angiotensin-Aldosterone System, which then results in different systemic effects like vasoconstriction, sodium water retention, an elevation in blood pressure, etc. So what is high yield here is to remember that we have these juxtaglomerular cells that sense pressure changes or stretch of the arterial walls. Then we have the macula densa, which senses low sodium levels in the distal tubule. So now let's turn our attention in greater detail to the RAAS cascade itself. So now then, in response to low blood pressure, we've come to learn that the kidney will release renin. Now, the liver releases something called angiotensinogen. And what renin does, it cleaves it into something called angiotensin 1. And angiotensin 1, in turn, is converted into angiotensin 2 by the enzyme ACE, which stands for angiotensin converting enzyme, and it is primarily in the lungs. So now we've arrived at angiotensin 2. And this is the second part of the Renin-Angiotensin-Aldosterone System. Now, angiotensin 2 acts on multiple targets. For example, we have vasoconstriction. So what it does, it contracts vascular smooth muscle, narrowing the lumen and increasing therefore systemic vascular resistance and blood pressure. Another effect is ADH secretion. So it stimulates the posterior pituitary gland, promoting therefore water retention and fluid intake by the release of antidiuretic hormone, ADH. Another key feature is the secretion of aldosterone. So it stimulates, angiotensin 2 stimulates the adrenal cortex, more specifically the zona glomerulosa, to release aldosterone. And aldosterone here, which makes up the third part of our RAAS system, aldosterone is a mineral corticoid that acts on the principal cells of the collecting duct in our nephron. It will lead to increased sodium reabsorption. It will also therefore increase potassium and hydrogen ion secretions. Now, with the increased sodium reabsorption, with the release of aldosterone, we will also see that water will follow, because water follows sodium osmotically. And all of this will contribute to blood volume expansion. Now, we also have RAAS-targeting medications, of course. Now, let's first mention the ACE inhibitors, so the angiotensin converting enzyme inhibitors. And if you remember, this was the enzyme here which converted angiotensin 1 into angiotensin 2. Examples of ACE inhibitors are Enalapril or Lisinopril. And what they do is exactly what was just mentioned. They block conversion of angiotensin 1 into angiotensin 2. Another group are the angiotensin receptor blockers, or ARBs. One example is Losartan. And these block the angiotensin 1 receptors. We also have other medications like aldosterone antagonists, specifically, like spironolactone, for example, and these block aldosterone receptors in the kidney. So we can see now the use of these medications, these drugs, in the treatment of hypertension, for example, heart failure, or chronic kidney disease, for example. Another group just worth mentioning, even though they're not used as often as ARBs or ACE inhibitors, are the DRIs, the direct renin inhibitors. So it's a class of medications that directly inhibit the activity of renin, which is the enzyme responsible for converting angiotensinogen into angiotensin 1, meaning the very first step of the RAAS cascade. Now let's dive a little bit deeper into the pathologies related to the RAAS system. So the one often mentioned is hyperaldosteronism, which is divided into primary and secondary hyperaldosteronism. Now in primary, it is characterized by autonomous aldosterone production, often due to, for example, adrenal adenoma. We call that Conn syndrome, or bilateral adrenal hyperplasia. We have familial hyperaldosteronism. So what is the clinical picture here? Well, we will see that renin levels are suppressed, but aldosterone is elevated. So the aldosterone to renin ratio is high. So if you think about it, we said that the afferent arterioles and the structures around it, they would sense a decrease in stretch, for example, or low sodium levels. In response to this, the juxtaglomerular apparatus, or the cell specifically, would release renin. And the whole purpose of renin was to initiate the RAAS cascade, ending with the elevation of blood pressure. But imagine if the issue isn't necessarily with the release or over-release of renin. Rather, one of these effects that follow from angiotensin 2, like for example the release of aldosterone, we will still see the same clinical effect, because aldosterone still elevates blood pressure. Vasoconstriction elevates blood pressure. So whatever elevates or increases the reabsorption of sodium and water will expand our blood volume, leading to an elevation of blood pressure. Now, for some reason, what we see here is an over-release of aldosterone. So our body will sense, due to the release of aldosterone, that we have an elevated blood volume. And when that happens, we will, through the process of negative feedback, not have renin released. So we will see a suppression of renin release. And a cause of this could indeed be, as we mentioned, for example, adrenal adenoma. Because at the adrenal cortex, if we have proliferation happening, we will still see an over-release of aldosterone with the same systemic effects as if renin had been released. So if we then look at the aldosterone to renin ratio, we will see that in primary hyperaldosteronism, renin is low, aldosterone is high, and the ratio is therefore high. But what about secondary hyperaldosteronism? This is caused by increased renin due to, for example, heart failure or cirrhosis or renal artery stenosis. So what will we see here? Well, if we have an increased renin release, we should still see the RAAS cascade in action, meaning a release of aldosterone. So we would expect a ratio to be either low or normal, because we will see high renin levels and high aldosterone levels. Now, even though hyperaldosteronism is typically the pathology mentioned in relation to the RAAS system, there are more. So let us just briefly take a look at a few others. So we've mentioned primary hyperaldosteronism or Conn's syndrome. We mentioned secondary. What about renal artery stenosis? So in renal artery stenosis, there is a narrowing of the renal artery, which reduces then blood flow to the affected kidney. It will therefore trick it, or it tricks it, into sensing hypotension, right? Because remember, the walls of the afferent arterioles are equipped with these cells that sense that there is a expansion or a stretch change of the walls due to low perfusion or overperfusion, etc. So if you have renal artery stenosis, you will have a narrowing of this artery. So there will be a reduced blood flow arriving to the kidney. And the system, therefore, will think, oh, there is hypotension here. There isn't enough pressure in this blood, right? So the RAAS system activates, and therefore we will see increased renin secretion. And if renin is released, we will see elevated angiotensin II, and therefore elevated aldosterone. And this then leads typically to refractory hypertension. We treat it with ACE inhibitors or with ARBs. Though bilateral stenosis may actually worsen kidney function if you use these drugs. So use it with caution here. What about chronic kidney disease? So in chronic kidney disease, there is a progressive nephron loss. And this will lead to impaired sodium excretion and a reduced renal perfusion. Now, this will stimulate chronic RAAS activation, again, elevating angiotensin II levels, leading to causing the afferent arterioles to vasoconstrict and glomerular hypertension, all contributing to proteinuria and further damage. And this is mitigated typically by ACE inhibitors or ARBs that reduce intraglomerular pressure and slows the progression. Final one we can take a look at is adrenal insufficiency, so Addison's. Now, in adrenal insufficiency, there is a failure of the adrenal cortex to produce aldosterone, which leads to impaired sodium reabsorption and instead to potassium and hydrogen retention in the distal nephron. This could result, therefore, in hyponatremia, hyperkalemia, hypotension, and volume depletion. Now, these are all corrected with a mineral corticoid replacement therapy, like fludrocortisone, for example. So you can see here that there are several pathologies that either directly or indirectly involve the RAAS system. Because of the massive consequences or effects, systemic effects of angiotensin II, both on our pituitary gland releasing ADH. We have it on our adrenal glands releasing aldosterone. We have the systemic vasoconstriction. We have sodium water retention and reabsorption, etc., etc. There are so many different systems involved. So I would definitely recommend repeating the subject of RAAS and its related pathologies in general. So in summary then, RAAS is central to blood pressure regulation, fluid balance, and cardiac remodeling. Its dysregulation causes significant pathology, and pharmacological interventions targeting RAAS are mainstays in modern cardiovascular and renal therapy. Key points related include the role of renin, ACE, so angiotensin converting enzyme, angiotensin II, aldosterone, antidiuretic hormone, the concept of vasoconstriction. RAAS targeting medications include mainly ACE inhibitors and angiotensin receptor blockers. And that's the end of this lecture. Please share, like, and subscribe for more weekly videos.